This talk is about the reverse shoulder prosthesis and how to do it from the surgeon point of view. This is my disclosure. Before you do it, I would like to be sure you understand it. Why is it called a reverse shoulder prosthesis? In a normal shoulder, the humeral side is convex and the glenoid side is concave. Like in an anatomic prosthesis on the left side of the slide, but on the contrary, in a reverse prosthesis, concavity is on the humeral side and convexity on the glenoid side. This is an inversion of the shoulder biomechanics. Why doing this? Reverse shoulder prosthesis has been imagined to make shoulder move without a functional rotator cuff. How does it work? The first point is that it's a constrained prosthesis transforming ascending forces of the deltoid into elevating forces for the shoulder and also making it stable. The second point is that there is a medialization of the center of rotation, which is now located on the glenoid surface to recruit more deltoid fibers. The third point, reverse prosthesis distalizes the humerus, which is around 3 centimeters lower than in a normal shoulder, to retention the deltoid fibers and increase the muscle strength. And all of this is making the shoulder move like this. Now let's have a look on the implants. First, the humeral implants. Here it is a long stem, classical long stem. It can be cemented or uncemented. There is various neck shaft angles from 155 degrees to 135 degrees, with an actual tendency to more vertical angles. There is a polyethylene liner on the top, adapted to the glenosphere, which is facing on the glenoid side. And there is many stems design, including long stems, short stems, and stemless. On the glenoid side, we use a metallic base plate fixed to the glenoid with a central peg and peripheral screws in most of the cases, but here again, different designs exist. And finally, the glenosphere is impacted or screwed on the base plate. There is various diameters, usually from 33 to 44 millimeters, to adapt to the anatomy of the patients. On the base plate, it's possible to add bone graft to lateralize the glenoid and to reconstruct bone defects when necessary, but I'll come back on that later on. Now, the indications for reverse shoulder arthroplasty, they are easy to remind. It is all the situation when the rotator cuff is torn or when the bone is missing, especially on the glenoid side. Initially, reverse prosthesis has been designed for to treat the cuff tear arthropathy, but now indications have extended to a large panel of situations, making the reverse the most used prosthesis in shoulder surgery. Now let's talk about doing a reverse. Before doing it, you have to plan it. 3D planning has developed these last 5 or 10 years, and to me, it's now mandatory before the surgery. It allows a precise shoulder evaluation, but also a virtual implantation of the prosthesis. That is to say, the choice of the type of prosthesis, the size and the position of the implants, but also anticipation of the difficulties during the surgery. You can eventually simulate the range of motion and compute a specific guide to improve accuracy in the OR. This is very interesting, and I encourage you to participate to this step with the surgeon you are working with. Now, the surgical approach. There is 2 different approaches to perform a reverse, both with advantages and limits. The first one is the superior approach. This is passing through the deltoid and even detach it from the acromion, like here. But it allows subscapularis preservation and improves prosthesis stability. You can see here the subscapularis at the anterior part of the shoulder on the left. Right, and Then the second approach is the deltopectoral approach or anterior approach. This is passing through the deltopectoral interval without injuring the muscles, but the access to the joint implies to cut the subscapularis. Here you can see the subscapularis stenotomy. And also an anterior release with a theoretical higher risk for instability. There is no proven superiority of one of these approaches, and this is up to the surgeon to use one or the other. So once the joint is exposed, we have to put the prosthesis inside. The first step is the humeral cut. It is located at the anatomical neck, and you can do it with a guide or freehand. This is up to the surgeon. And then the humeral head is removed, and it can be used as a graft if necessary. Then the humerus is prepared using a broach, using broaches of increasing size until we reach a good stability. Here you can see the first broach is not stable, so we use the second one, and here the stability is correct. The size of the final broach gives the size of the humeral implant. Then the glenoid is exposed, which usually requires a meticulous capsular release. The first step is the positioning of the guide wire. Then we use a reamer to flatten the glenoid surface. And finally, we prepare the peg hole for the implant. When everything is done, we start implanting the glenoid base plate with the screws. Then the glenosphere, which is impacted and screwed on the base plate. And finally, the humeral implant, which is implanted without cement here. And finally, the polyethylene liner. Then we can reduce the joint and make the shoulder move to test the range of motion and the stability of the prosthesis. Right. Now, I would like to talk about the concept of glenoid lateralization. What is it, why we do it, and how to do it? Glenoid lateralization consists in making the center of rotation of the prosthesis more lateral and moving the humeral implant away from the scapular pillar. It improves range of motion, especially the rotation. It increases stability, and it limits the scapular notching phenomenon. It's also a useful technique to reconstruct bone defects on the glenoid side when necessary. We have two options to make a glenoid lateralization. The bony lateralization, as known as BioRSA, using humeral head bone in most of the cases, but you can also use iliac crest or allograft, and metallic lateralization with specifically designed implants. Bony lateralization uses a bone graft that is harvested from the humeral head. The shape of the graft is adapted to the patient. It can be symmetric, angulated, or even patient-specific. The graft can be taken from the head directly on the patient. This is the classical technique on the left, but also on the table, which can be easier when using a superior approach. In my practice, I use specific instruments to harvest the graft on the table. Here you can see the instrument. This is an angulated graft here, 15 degree. And once the graft is done, we prepare the glenoid with the same angulation, 15 degree. And then the graft is fixed on the base plate before implantation. Here you can see the graft between the implants and the glenoid. Metallic lateralization needs specifically designed implants with metallic compensation directly on the base plate. It can be used for every case, but it is especially useful when humeral head bone is missing, in case of revision or complex cases with destruction of the humeral head. My last words will be about the postoperative cares. After a reverse, there is no consensus and many protocols exist. Personally, I use a protection sling for the first 3 or 4 weeks, but the patient is free to remove it if he feels comfortable without any sling. I especially like this one because there is a 10-degree abduction pillow which relaxes the deltoid and because the position is close to the neutral position of the shoulder. Rehabilitation usually starts just after the surgery with passive motion and isometric contraction of the deltoid. In my practice, I do not limit the range of motion in elevation or in rotation, and I start active motion as soon as the patient can do it pain-free. 3 to 6 months are usually necessary to recover for most of the patient. It can sometimes be longer, but sometimes it can also be very quick, like this woman the day after surgery. Thank you.